Good morning, sir.
Good morning. Good morning. We'll start in a while. Where is Apurva?
Good morning, sir.
Good morning. Okay, Apurva, let us start.
હા સાહેબ, અને સતો સર સાથે કીધું કે જોઈન કરી જ રહ્યો છું.
Okay, no issue. No issue.
આપણે ચાલુ કરી દો. Thank you, sir.
Okay, I think everybody is aware of the rules. Apurva will tell you, and let us start. Okay.
So basically, this is like a PG exam where the student will, of course, it's on the virtual platform where he will first of all tell the history, the summary of the history, and then the investigations and the diagnosis and the treatment part. The examiners as well as the experts are free to ask questions at any given time, but it will be good if they allow the student to complete the exam and then we can ask the question slide by slide. And
okay, Apurva, one thing, after history, we will have a break and discuss about history, followed
yes,
by
sir.
examination.
Yes, sir.
And
Yes,
then
sir. Same
again
thing.
like
Yes,
that.
sir. Right, sir. Oh, we can start, sir, then.
Shivang, share your slides. Daivat, welcome. Okay.
Good morning, sir.
Good morning.
Dr. Daivat and Dr. Vivek Joshi are with us. They are the experts. Vivek Joshi is a gastroenterologist. Vivek Joshi. Vivek?
Where is he?
Yes, sir. Am I audible?
Yeah. Okay, fine.
Yeah.
Thank you. Thanks for joining.
Good
So I am talking. Vivek,
Yes.
Vivek, are you there?
Yes,
Okay.
yes, sir. Yes, sir. I am here.
Okay, great. अला दाढ़ी बाड़ी बनाई दी थी तेरे सीनियर देखा
जस्ट सर राउंड थी આવે પાછા સવારે રાઉન્ડ હતા એટલે હેલો
Yes, start beta.
yes
Hello. Good evening, sir. Hello. 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 Am I audible, sir?
Yes, you are audible. Continue.
Yes, sir. Good evening, sir. Sir, myself, Dr. Shivankot, presenting a case on abdominal case presentation on abdominal lump of splenomegaly. Under guidance of Dr. Nina M. Shah, HOU, Dr. Pankaj R. Modi, sir, HOU, Dr. Apurvaji Shah, sir, HOU, Dr. Hiralji Chauhan, ma'am, Assistant Professor, and Dr. Hardik Pipat, sir, Assistant Professor. A 38-year-old female patient working as a laborer in farm and residing at the remote village of Porbandar, Gujarat, presented to general surgical OPD with complaint of upper abdominal pain since 2 days. A patient was relatively asymptomatic before 2 days. Then she developed upper abdominal pain more toward left side, which was insidious in onset, dull aching, non-radiating, with no relation to food intake or any exaggerating or relieving factors. There is history of lower limb edema 4 months before. At that time, 4 units of blood transfusion was done. There is history of fever with body ache was present 1 year back, and at that time, 2 units of blood transfusion was done. There is history of 4 to 5 units of blood transfusion 5 years back, and at that time of bearing of second child on the 8th month of ANC with development of fever and rash. There is history of fever with 4 units of blood transfusion at the age of 18 years. There is history of also fever with 2 units of blood transfusion at the age of 2 years. There is no history of vomiting, hematemesis, melena, weight loss, jaundice, postprandial fullness, abdominal distension, or fever. Past history. There is no history of similar complaint before. There is no history of any surgery, no history of any liver disease, tuberculosis, diabetic mellitus, hypertension, cardiovascular disease, or any respiratory disease. Personal history. Menstrual history. Patient's last menstrual period was on 1st of September 2024 with a regular 28-day cycle for 4 to 5 days. It was painless and there was no passage of clots per vagina. Patient is gravida 2, para 2 with no abortion and with 2 living child. First child is a 9-year-old female with normal vaginal delivery at GG Hospital, Jamnagar. a 5-year-old male child with normal vaginal delivery at GG Hospital, Jamnagar, and at that time, 4 to 5 units of blood transfusion was done with query blood transfusion reaction. Patient consumes vegetarian diet. She has normal appetite and unaltered bowel and bladder habit with adequate sleep. There is no any addiction or drug history. Family history. There is no history of similar complaint in the family. There is no history of blood transfusion or cancer among the family member. Summary. A 34-year-old female patient presented with a chief complaint of left upper abdominal pain since 2 days with history of multiple blood transfusions since age of 2 years without any history of hematemesis or malignant.
Okay, Shivang, stop now. Yes, examiners or experts, please. Any questions
Yeah.
about history? Yeah,
May
because it is
may I-
definitely there is bound to be some questions. Please.
may I speak, sir?
Yeah, most welcome.
Yeah.
Hmm.
Sivang, there very much discrepancy on your history. In practical view, if only pain in a left upper abdomen of 2 days, how patient all the way from Porbandar to reach to the Ahmedabad? Number one, because already GG hospital is there. Already vaginal delivery was done. There already.
Yes,
So
sir.
only for 2 days is dull aching pain. Only for dull aching, if acute onset throbbing something is there, then patient may reach all the way from 350 kilometers. So the history must be longer.
Uh,
Number one. Number two, so many blood
sir.
transfusions, but have you not inquired, but not given a reason why they have given so much of blood transfusion each time of fever? Patient also must be worried. If by each time only fever and blood transfusion, how many times you give each time? Fever and blood transfusion, there is no correlation. Fever for fever, there is some antibiotic or something. Then why so many blood transfusion? We have not inquired in history. અને કોઈક લેવલે તો any level must have patient have been explained you have this even for normal delivery if there is no cesarean section. So in normal delivery 4-5 blood transfusions were given. So at that time also patient must be explained some reason why you have given 4-5 blood transfusions. Almost 20 blood transfusions are given. You have given the history. But in history, I have not mentioned that they have explained or they have given something must be there.
Sir, patient patient is shown to the private hospital, and they have referred to the our hospital, sir.
Shivang, show your face and keep the slides. Continue sharing the slide because we can have whichever slide we wish. So Shivang sir is asking how come in 2 days history patient has come to see me, right? And what did you suspect after so many of blood transfusions? Hello.
Sorry, sir. Connection. Yes, sir.
Yeah. Continue till then. Let it be connected. Okay.
Yes, sir. It's done, sir. Hello.
One thing is very clear. The blood transfusions are given, but they are erratic. Means it is not a regular
Hello.
transfusion.
Am I audible, sir?
Yeah, you are quite audible. Yeah.
Yes, sir.
But slide share is gone.
Moreover, the blood transfusions are given again and again, so he must be having some symptoms related to that blood. The patient must be having some fatigue or some problem. So that also you have not asked that what problem was there that again and again this blood transfusion was given.
Sir, before that, patient so patient has went to the private hospital, and at that time she was given to the blood transfusion. And starting from the age of 2 years, patient has first developed fever.
Shivang, 1 minute.
Yes, sir.
What did you suspect? Let us talk to that. Okay. Means there is a history of multiple blood transfusion. There is also a question which is to be answered. Should we include this all history in chief complaint or not? That is the one more point. But according to you, patient had come for only pain in abdomen. On asking, the retrograde history was discovered, right? That's what you want to say. The point what we want to know is what did you suspect or what are the questions you asked when these many blood transfusions were given?
Sir, I asked about the frequency of blood transfusion.
No,
And
that is fine. That you
starting
have
from
already
which
said. Okay, now it is better. Yes, we should be sharing the slide. Right. Come on. Yes.
Yes,
Okay.
sir.
So what did you suspect? And what are the
Sir,
questions you asked? That's what I think you want to know.
Sir, first I suspected that patient is having a maybe nutritional deficiency anemia or some kind of a peptic ulcer disease, or it could be hemoglobinopathies which required multiple transfusions, sir.
Daivat, unmute yourself. I think it is not. At the age of 2 years, first transfusion given, and you are suspecting peptic disease?
Sir, after 2 years to age of the 18 year, there was no transfusion.
But you suspect that at the age of 2 years there were peptic perforation or peptic disease which caused the blood transfusion to be so that
no, sir.
Answer should be logical. Whatever you feel, you can answer. Daivat,
so at the age of 2 years, if what is the first DD? Suppose at 2 years, at 18 years, at 28 years.
Sir, thalassemia.
Yes.
Thalassemia or
okay, yes.
hemoglobinopathy, sir.
Okay, thalassemia or hemoglobinopathy, but that at time may not be detected or not be investigated. Okay, next, if suppose 28-year-old at the time of delivery, first blood transfusion given, no other issue, then what is your DD, first DD?
Sir, two of them out of 5, one transfusion was given at the time of pregnancy, and other one are there was associated with a fever or there was some other problem.
Shivang,
Yes, sir.
hear myself.
Yes, sir.
What is the question? What did you suspect? We are not asking how many blood transfusion, how they were given. When at the age of 28 years, blood transfusion were given, what was possibility you thought of? Don't give same history repeatedly.
Sir,
understand the question before answering. Wait for a second. Understand the question. Question is, what did you suspect?
Hemoglobinopathies or portal hypertension, sir, with anemia.
At the age of 28, I'm saying, at 2 years is different. At 28, maybe first differential diagnosis may or may be different. Okay. One is the extrahepatic. Okay, one is there. Then you can come nutritional or anemia and all this. You may be suspect.
So why did you suspect thalassemia? Why not any other hemolytic anemia?
Other hemolysis.
So your answer should be some kind of hemolytic anemia or hemoglobinopathy. Well, how did you suspect thalassemia? First, what was the reason for suspecting thalassemia?
Sir, hemolysis was anemic episode was started at quite young age.
Okay, but after that,
it is more common, sir.
Dr. Shivang, patient will not be needing blood transfusion for another 26 years. Thalassemia is very unlikely because thalassemic patients, if you see in your OPDs, they are usually getting blood transfusions every 2 to 3 weeks. So 2 years first transfusion and then 28 years second transfusion, the etiologies might be different for both the blood transfusions.
Yes, sir. My other DDs were, sir, any G6PD deficiency anemia or hereditary spherocytosis.
No. Each time patient has crisis. Each time patient has crisis. And at the time of crisis, patient requires blood transfusion. This is a clear indication that some other hemoglobinopathy may be there.
Yes,
each time fever and at the time of fever, patient needs some blood transfusion. So it is not thalassemia, but something else, hemoglobinopathy may be there. Which one is there?
Sickle cell.
Satoshka sir, I think you have joined, sir.
Oh. Shivang, again
Yes,
understand
sir.
the question and then answer.
Sir, sickle cell anemia, G6PD deficiency, or hereditary spherocytosis, sir.
Yeah.
G6PD deficiency, how common do you suspect in a female? Is it common that much? Yes, it can
No,
happen.
sir.
It can happen. No, it can happen, but it is not that common
Yes,
in
sir.
females, usually, G6PD deficiency. Yeah.
And same
Okay.
thing goes for hereditary spherocytosis. Again, in female, it is extremely rare, right? So the what is the moral of story, Sivang, is don't get biased, and that is for all PGs. You must have seen the reports. So you are stop on thalassemia. So does thalassemia present like this? That's the question. Whatever may be ultimate result, or your investigation may suggest anything, but in present history circumstances, would you put thalassemia as the first possibility?
No, sir.
Why not? That is again I am repeating myself. Why not? Now answer it.
Sir, each
Daivat has
time
already explained it.
संतोष सर साहब ने ज्वाइन किया है
any
आप लैपटॉप
stressful
पर
condition was there was a blood transfusion. That's why, sir.
अच्छा
And
ठीक है सर तो
frequency
मैं
of
उसे
blood
ज्वाइन किया लेकिन
transfusion
मुझे
was
दिखाई
less,
नहीं दे
sir,
रहा है
as
इसलिए
was
ठीक है
routinely
चले
observed
ठीक
in
ठीक
thalassemia patients, sir.
So your answer should be like some hemoglobinopathy must be there. Which one we don't know from history. That investigation only will say further, or further examination will say.
Okay. Any other questions regarding history, Vivek?
Yes,
Daivat?
sir. So, Dr. Shivang, my question, the slide that you have shared of clinical history, do you think there is any grammatical error? Because you might get caught up in grammatical errors during your history presentation. When you start presenting, even if you are correct clinically, some examiner might catch you in your grammatical errors. Do you think there is some grammatical error in your these two or three sentences that you have mentioned?
Sir,
You have
spelling of
written
fever.
complaint of upper abdominal pain since 2 days. Since is from the point of time, and if you are writing 2 days, then it should be for 2 days. You might get caught up in this. If some examiner want to have some grudges against you, then even from this, your history might get deviated to something else. So upper
Yes.
abdominal pain for 2 days, and if you are writing since, if you are speaking since, then since today is 21st, or since 19th of September, you have to mention like that. Okay.
Yes.
Yeah.
डॉक्टर संतोष का सर आर यू देयर सर डॉक्टर राजीव संतोष का सर
Sir, he is not visible in the. Still, he is not
क्या
visible.
अरे उन्होंने बोला कि मैंने ज्वाइन किया है
I
आई डोंट नो
think there is a one Samsung. I think I saw him for a minute.
संतोष का साहब
I
ओके
did
आई
see.
कॉल हिम सर
Okay,
आई
just
कॉल हिम अगेन
okay. Let us continue. Shiva.
Yeah.
So,
Yes,
what are
sir.
the other important history you have asked in?
Sir, I have asked the history of jaundice, history of hematemesis and melena, and a history of abdominal distension, sir.
Mhm. Anything else?
Sir, history of weight loss.
Mhm. Okay. So, why did you suspect sickle cell anemia?
Sir, patient was having blood transfusion at the time of any infection or some stressful condition, sir.
Mhm.
Such as at the time of delivery, and as mentioned by patient as per history, sir, patient was having fever at the time of blood transfusion.
Okay, that is the one point. Any other point?
Patient is around the sir coming from area around the sir Porbandar. Which area is more common for hemoglobinopathy, sir?
Why? Which
Sir,
community
in
patient
that,
is from?
sir, patient is from
Community.
yes, sir, Harijan
So, which
community, sir.
community has a commonly have a particularly G6PD deficiency is very common in them? Which group? Thakkar,
Sir,
Lohit. They have.
Sindhis and
Pardon?
Sindhis and Kansara, sir. having more hemoglobin of
They are
80.
not common in Porbandar. It's a Thakkar community. They do have a G6PD deficiency is much more common in them, right? So that is the one more.
Yes,
Vinith,
yes, sir.
would you like to ask anything? You are muted. That is the problem.
No, sir. I think we can continue.
Okay. Daivat, you think it?
Yes, sir,
Okay.
we can proceed.
Okay. So let us go to examination.
Another thing, Dr. Shivang. So for abdominal pain, what other characteristics will you ask? You have mentioned your chief complaint is abdominal pain.
Yes, sir.
So what are the points that you will ask in this patient in
Sir,
your
I will ask.
history?
I will ask for the site of the abdominal pain in its nature, and
Hmm.
how the pain was progressed, and whether it is has any relation with the food or not, and if there are any exaggerating or relieving
Okay.
factors are present or not.
Okay. So your pain did not aggravate, right? Correct. Okay. You can continue.
Should I go for
Yeah.
examination, sir?
Yes, please.
General examination. I have examined patient in adequate light and exposure in presence of female attendant after informed consent by maintaining her privacy. A patient is conscious, cooperative, and well oriented to time, place, and person. She is well built and fairly knowledge with Karnofsky score of 80. Temperature is normal. Her pulse is 90 beats per minute in the right radial artery. Her blood pressure is 110 by 70 millimeter of mercury in right brachial artery. Pallor is present in the conjunctiva and the tongue. There was no jaundice, cyanosis, clubbing, edema, or lymphadenopathy. Systemic
What is normal
examination.
temperature, Dr. Shivang? What is normal temperature?
Sir, 36 degree centigrade, sir.
No, you have to mention the temperature, not tell it by normal by palpatory method or something, because the examiner might catch you in this as well. What is normal by palpatory method? Don't you have thermometers in your wards? You have thermometers, right? So you can just mention whether it is 98 degree Fahrenheit or 97, 98.6, whatever the value that you have to mention, because you have written everything, pulse, BP, everything is fine in numerical values. Then always better mention it. What is the value of temperature?
Yes,
Sir, he mentioned 36 degrees Celsius. He just now
Yes.
said 36.
Yes, correct. Okay.
On systemic examination, for abdominal examination, on inspection, abdomen is scaphoid, umbilicus is normal in size, shape,
Good
and
morning,
location.
sir. Welcome.
Thank you, sir. Thank you.
Please, thank you for joining.
You said umbilicus is normal. So, in abdomen, what are the abnormalities of umbilicus that you can expect? What are the different abnormalities of umbilicus?
Sir, umbilicus can be first on the location, sir. Umbilicus in a fatty patient, it may be lower down as compared to the sir flat or scaphoid abdomen, in which it is placed in a central location. If a patient having abdominal distension, then it also umbilicus is placed on the lower part of the abdomen, sir. Uh, in a distension or any presence of ascites, the umbilicus will be transversely stretched, or it can be everted.
Yes, it can be everted. Yes.
Yes.
And in case of fatty patient, what about the depth of the umbilicus?
Sorry, sir.
How will you know whether the abdomen is distended or if there is a layer of fat on the abdominal wall? How will
Sir,
you
if
know?
the distended abdomen will have a tense and a shiny skin.
No, by looking at umbilicus.
Sir, if
What
abdominal
will be the
distension
difference?
is present, then umbilicus will be everted, sir. And while if due to if fatty patient umbilicus is lower down due to obesity, sir, then
No, the
it won't be everted, sir.
depth
It
of
will be deep, sir.
umbilicus will be much more in fatty patient. Depth of umbilicus will be much more in fatty
Yes, sir.
patient. What is the third abnormality of the umbilicus?
It will be transversely stretched, sir.
Yes, it can be transversely stretched, it can be everted, or it can be deep or there can be a discharge coming from the umbilicus.
Umbilicus.
Yes, you can get discharge coming from the umbilicus. What is omphalitis?
Sir, omphalitis is a infection of umbilicus, which is usually due to improper. There may be some underlying umbilical cage delay, sir.
Generally, omphalitis is because of what?
Sir, in neonates, it is due to application of cow dung around the umbilical cord, sir.
No. See, neonates, because of application of cow dung, do you get omphalitis or do you get thrombosis of some vein?
Yes, sir. It will progress to the thrombosis of the median umbilical vein, sir.
Then you generally it presents in the form of thrombosis of the umbilical vein. Omphalitis is generally seen in adults and it is because of,
Improper hygiene, sir.
yes, but what leads to omphalitis? People try to put fingers in the umbilicus, try to clean it or something like that, and then it leads to omphalitis. Any other congenital cause because of you can get discharge from umbilicus or omphalitis?
Sir, there can be persistent vitalointestinal duct, or there can be
Yes, yes, yes,
persistent urachus, sir.
yes. So, what is it known as? Patent?
Vitalointestinal duct, sir. Patent.
Patent? Is it patent urachus? It is not vitellointestinal. What is patent urachus?
Sir, urachus is draining bladder, draining urine from the bladder to the from the umbilicus toward the yolk sac in the intrauterine life.
So
After
generally it gets obliterated.
obliterated, sir.
If it remains patent, then there can be a discharge from the
Umbilicus.
umbilicus.
Yes, sir.
Okay. What is if there is congenital abnormality of the umbilicus? It can involve even deficient wall anterior. It is known as
Exo exophthalmos.
exophthalmos नहीं, वो bladder का क्या ectopia?
Ectopia vazaiki.
Yes. Okay. So see, you can be examined on any topic. You see. Yeah. Chalo, next. So that is about the umbilicus. Umbilicus normal.
There was no visible scar, dilated vein, visible peristalsis, redness, or thin
Why are
swelling.
you talking about dilated veins? Which condition do you get dilated veins on the abdomen?
Sir, in portal hypertension, I will get dilated vein.
So do you expect any dilated veins in this particular case of splenomegaly? Can you get portal hypertension in case of splenomegaly?
Yes, sir. If patient may have extrahepatic portal vein occlusion or Budd-Chiari syndrome, then there will be such.
That is portal hypertension. Here there is no extrahepatic portal obstruction. So can you get portal hypertension still if the vein spleen is enlarged? What are the circulatory causes of splenomegaly? There are various causes of splenomegaly: infective, blood disorder, metabolic.
Sir, congestive heart failure can be
Yeah,
a reason
no.
to splenomegaly.
Circulatory causes of splenomegaly. Congestive heart failure, obviously you are not going to get portal hypertension, but you have any other splenomegaly where there is a hyperdynamic circulation. Where there is hyperdynamic circulation. Any splenomegaly, large splenomegaly where there is hyperdynamic circulation. Suppose you have Kala-Azar, you have a large spleen, and the spleen is taking large amount of blood.
Yeah.
Can you get portal signs of portal? Of course, it is not as severe as extrahepatic portal obstruction. The patient may have varices little bit or may not have varices. Mainly it presents in the form of ascites. Okay. But there is a hyperdynamic circulation, there is portal hypertension. So you have a little mild dilatation of the portal vein and so on. So that is what is circulatory cause, high portal hypertension. That is hyperdynamic circulation. In India, you need to think about this because of Kala Azar. You get large splenomegaly in Kala Azar. What is the cause of Kala Azar? What gives rise to Kala Azar?
Sir, Leishmania. It is a parasitic infection, protozoan infection by Leishmania donovan, sir.
Yes. Now you have Leishmania. How do you establish the diagnosis of Leishmania?
Sir, it is the uh, uh, protozoa, demonstration of protozoa in the Leishmania, sir.
Okay. And what is the treatment of Leishmania? Yes. For spleen, you might like to do splenomegaly, but otherwise, how do you control trypanosome? What is
Quinine. Quinine group.
stevogluconate?
Sorry, sir.
Anyway, it
Yes,
is
sodium
generally we
stevogluconate.
used to use antimony compounds, that is stevogluconate. And if at all the trypanosomiasis or trypanosoma where active trypanosoma was found, otherwise we would treat it as a splenomegaly. Okay, so that is about the visible veins. Okay, so how much you can be asked on visible veins, isn't it?
Yes.
So next, go back to
Hernial sites.
yeah.
Hernial sites are normal and Becken spine
Why
examination
you
is
have to
normal,
check
sir.
about hernial sites in case of splenomegaly? Which conditions of splenomegaly you can get, you know, say hernia or more commonly congenital hydrocele? See, you are
Sir,
talking about portal hypertension.
yes, sir. If a splenomegaly associated with ascites, then umbilical hernia can be present, sir.
Yes, one is umbilical hernia, or there can be ascites, and which ascites can trickle down into the hernia sac of inguinal hernia. If at all there was a sac existing, something like congenital
Yes,
hydrocele,
sir.
the fluid can trickle down into that sac, and that can give rise to, inguinal hernia.
Yes, sir.
Okay,
Yes,
so
sir.
that is why you need to check. Normally, which hernia was not there because of ascites fluid flowing down into the hernial sac, and then hernial sac becoming prominent. You can get ascites when there is a when there is a portal hypertension. And obviously, portal hypertension is one of the cause of splenomegaly. So
Yes, sir.
it is cirrhosis of liver, ascites, portal hypertension, splenomegaly, and then patient comes to you like this, and then you are examining him. So that is why hernial site you have to look for.
Yes.
So back and spine.
Yes.
Okay.
Yes, sir.
Then
On palpation, temperature is normal. There is no tenderness. Liver is at 3 finger below post margin
why have you
clavicular line
why
with
this
rounded
is
edge.
just a minute. Why have you checked for temperature?
Sir, before any palpation, temperature should be checked. Because
Yes,
if
but see,
we
but what
because
is the principle of checking temperature? You have to have
sir,
direct contact with the swelling. Yes?
yes, sir. Sir, any inflammatory swelling will have temperature
Yes,
raised, sir.
yes,
And
yes.
if we examine first and temperature in last, then manipulation of swelling will increase the temperature, sir.
But in this
That means that, sir.
case, you are right in saying temperature, but in this case, there is a abdominal wall in between your spleen or whatever that lump is. Up till now, we don't know what that lump is. There is an abdominal wall
Yes, sir.
in between the lump and your hand, right?
Yes, sir.
So do you think that you will be able to appreciate the temperature of the lump through the abdominal wall?
No, sir.
Then, see, your answer is absolutely correct. The temperature you have to see, but you are correct. But why? I want to know why you are correct.
Sir, any superficial redness or
Yes,
condition
but
is
why
present?
there will be superficial redness in case of any infective intra-abdominal swelling? Why there will be superficial redness? You are right, there will be superficial redness. But why? See, whenever there is an inflammation, inflammation is a pathological process. And inflammation doesn't say that the inflammation is only in spleen or only in abdominal organ. So I will stay only in spleen. I will not go beyond spleen. Spleen or abdominal organs are in constant touch with the abdominal wall. So whenever the organs are getting inflamed, whatever process is going on into the organ will also affect the tissue which is in immediate vicinity of that particular and in contact with that particular inflamed organ. And inflammation is not going to say no. Even if the abdominal wall is touching me, I will get restricted only to the spleen or whatever organ is. So generally the inflammation gets extended into the tissues which are with that particular organ and in contact with that particular organ. So any intra-abdominal organ, there is an inflammation. Whichever part of abdominal organ is touching that organ, the inflammation will get extended into that part of the abdominal wall. So you will be able to appreciate the temperature. You understand my point? You will not be
Yes,
taking
sir.
the temperature from the abdomen, from the organ, but you are going to take it from the wall which is in contact with the organ, and because of the organ, that wall portion also is inflamed, and you are getting that rise of temperature not directly but indirectly. Okay.
Yes, sir.
So what
Liver
next?
is Liver is enlarged 3 finger breadth below costal margin at the mid-clavicle line with rounded edge, smooth surface, and uniform consistency. Spleen is enlarged with inferior pole located at 7 cm below costal margin and 5 cm lateral to the midline on left side with smooth surface and uniform consistency. Notch is palpable over the interior border 3 cm from inferior pole toward the cranium.
Yes. So now I am tempted to ask you a very standard and usual question over here. How do you differentiate between renal swelling and splenic lung? What are the
Sir, in
different
case of
points? It's a very standard question, and you can expect it in any examination where the spleen is your case.
yes, sir. So spleen is enlarged toward the right iliac fossa from the left
Why
subcostal margin,
spleen
which
enlarged
is
towards right iliac fossa? Why it enlarges towards right iliac fossa? There are two organs. You have got liver. Okay,
yes, sir.
you have got liver, you have got spleen. Liver enlarges, it doesn't go to the left iliac fossa, it goes to the right iliac fossa downwards. Then why spleen goes
Yes, sir.
towards the right iliac fossa?
Sir, main axis of the spleen is toward the sir, right iliac fossa. It is located
Why?
in the
Why?
left.
But why axis of the spleen is towards right iliac fossa?
Sir, due to attachment of
What
spleen,
makes the axis of the spleen towards right iliac fossa? Yes, what? So what attachment of spleen which gives it the axis towards the right iliac fossa? You know what is phrenicocholic ligament?
yes, sir.
It is because of the
Atta-
phrenicocholic ligament, the spleen's axis. That is not the direct attachment of the axis of the spleen towards right iliac fossa. That's why the spleen enlarges into the right iliac fossa.
Yes, sir.
Okay, so that is about the direction of axis. So what is the next point?
Sir, renal swelling will be toward the downward side or the sir
अरे ऐसा
lateral
नहीं होता
axis.
है ये डाउनवर्ड अपवर्ड ऐसा नहीं you are examining the so you have examining the thing ये सब is acceptable in your inspection in examination you have to be very precise so direction of axis accepted shape of swelling का कुछ
Shape of
renal
swelling in case of renal swelling is a reniform swelling, while in case
रेनिफॉर्म
of
नहीं रेनिफॉर्म से बेटर क्या है रेनिफॉर्म yes but what is that रेनिफॉर्म shape bean shape
bean shapes.
yeah so the shape of swelling will be bean shape
Bean shape.
this axis will be towards right angle that axis will not be towards right iliac fossa okay then what
Yes. In case of splenic swelling, notch will splenic enlargement notch will be palpated over this anterior border.
yeah
And
notch
no
will
notch will
not
be
be
palpated.
palpated on the renal swelling then
Splenic swelling will move freely with the respiration, while
yes, it
renal
will
swelling
move
will move
freely
very
with
little.
the respiration. Renal swelling will not move that freely. It will not move freely with the respiration.
Respiratory.
Yes, that is true.
In
Then,
case of a splenic swelling, there on percussion it will be dull in percussion, and
yes,
while in renal swelling from anteriorly it will be resonant due to sir small intestine.
yes, but what is that resonance known as? Is there a particular terminology to describe that resonance?
Uh, Sir, over the on the back toward the lateral side to the erector spine, there will be colonic band of resonance, sir, uh,
Yes.
which is
So
present over the renal
you
swelling.
say that, na? Colonic band of resonance. Colonic band of resonance will
Yes,
be
sir.
present on the anterior side of the renal swelling.
Yes.
Okay, so that is what. So many points we have, considered to differentiate between renal swelling and
Another point I want to add, is the spleen palatable or not?
No, sir.
So what is
Splenic
palatable?
swelling is not. Uh, Palatability is assessed by placing one hand behind at the back and one hand over the anterior aspect, and then we try to palpate swelling by pushing from one hand anteroposteriorly, sir.
now I am again tempted at this stage. This is again standard question. No difference between ballotment and bimanually palpable. Which
Sir,
swelling
in
you will call bimanually palpable? Which swelling you will call ballotable?
sir, bimanual palpation means the swelling is palpated between the both hand, and both hand are touching at the swelling at the simultaneous point, simultaneously.
Yes,
While
yes. So
ballotment,
which swellings will be bimanually palpable? This is again a standard question. So you must prepare answer to this and go. Whenever there is a discussion on kidney, this question will be 100% will be asked you. Generally, large swellings, which you can feel without the movement of the swelling. Without the
yes, sir.
movement of the swelling, if you can feel it between the two palpating hands, then it is bimanually
By
palpable. Certain amount of movement of anterior abdominal wall may be there, maybe 0.5. You may have to press the anterior abdominal wall by about half a centimeter or so, but there is no movement. But you don't have to move the swelling. The swelling remains wherever it is. That is bimanual palpable. And when you have to make the movement of the swelling so as to make the other hand feel that swelling, that is ballotment of the swelling.
Yes.
And lastly, the difference between the renal swelling and the splenic swelling is a movement. Generally, splenic swelling is mobile. There is a mobility with the splenic swelling. Renal swellings don't have that much of mobility.
Yes.
Okay, so many points.
So can you tell me what are the cause? You said that no tenderness. So what is the cause, differential diagnosis of tender splenomegaly?
Sir, tender splenomegaly is seen in case of a splenic abscess, sir. Splenic
Only split.
hematoma,
Then
splenic abscess, splenic hematoma, sir. Malaria and Kala azar can also give rise to sir tender splenomegaly, sir.
Do you see tender splenomegaly in splenic hematoma? How does the splenic hematoma present? Will it remain there for you to palpate? Or when you palpate the splenic hematoma, what is the danger?
Mm, Sir, when splenic
Chalo,
hematoma,
anyway, at MS level, I'll grant you this particular question. No problem. Chalo, go
okay.
ahead.
Okay. One question. Why so you say that it's spleen? Why it is not left lobe hepatomegaly?
sir, liver superior margin of the spleen is not it is not palpable. It is toward the right subcostal region, and swelling direction of the swelling is from right subcostal region to the right iliac fossa, sir. While in case of left lobe, if liver enlargement is there, then it will be continuous with uh, parallel to the right subcostal margin, sir.
Okay. You said that on palpation the spleen is smooth surface. Okay. So what are
Yes,
the
sir.
causes of nodular spleen?
So nodular spleen is seen in case of if hydrated disease of the spleen is present, and storage disease is sir, nodular spleen.
So storage disease does what do you mean by storage disease? Storage disease, all the storage disease doesn't have the multinodular spleen.
Gochas disease, sir.
Roach's disease you will never find nodular spleen. Any other thing? Polycystic spleen. Then
Yes,
multiple mats in the spleen.
yes. Tuberculosis.
Tuberculosis, granulomatous disease. Okay?
Yes, sir.
Hmm. Go ahead.
One question that uh, now it's a case of not only splenomegaly, looks like hepatosplenomegaly also. Now, what is your another along with spleen with liver is also enlarged? What is your DD now?
Sir, hemolytic anemia, sir.
See, what is the size of the liver? Liver is about 3 finger. Spleen is about how much size of the spleen is? Have you said? How much is
Sir,
it?
7 centimeter below coastal margin, sir.
7 centimeters.
Yes, sir.
See, do you get such a large splenomegaly or hepatomegaly in case of hemolytic anemia?
Raju,
Your three things.
yes,
Plain
Yes, sir.
splenomegaly, causes of plain splenomegaly.
PRM sir,
Second, hepatomegaly, plain hepatomegaly, causes of hepatomegaly. And third
Yes,
is causes of hepatosplenomegaly.
yes, sir.
Now, here at the end of your clinical examination, you find that there is a significant of hepatosplenomegaly.
Yes, sir.
It is not just a single finger palpable or, just about 3, 4 centimeter, 5 centimeter palpable spleen. It's a significant large spleen plus large hepatomegaly.
Yes, sir.
So whenever you are getting hepatomegaly and splenic megaly, you must have pathology which is affecting both liver as well as spleen,
Yes, sir.
isn't it?
Yes, sir.
So the foremost pathology which affects liver and spleen simultaneously is what? There is a system of body which is existent in both spleen as well as your liver.
Yes, sir.
That is
Reticuloendothelial.
yes. So, is there anything in the reticuloendothelial system that can give rise to both hepatosplenomegaly,
Sir,
which is a
infection of reticuloendothelial system or malignancy involving, sir.
yes. So, which malignancies can give rise to hepatosplenomegaly? Both.
Sir, leukemia, sir.
Yes, absolutely. Leukemias can give rise to. Is there any other pathology which can involve both the systems simultaneously?
Yes,
Parasitic
sir.
disorders.
Leishmaniasis can also involve hepatosplenomegaly, both spleen and liver, sir.
Leishmaniasis, what about trypanosomiasis? Can it not involve
Yes, sir. And
both?
leptospirosis, sir.
Yes. So, what about Kala Azar? Can it not involve both liver as well as spleen?
Yes, sir.
Then what is circulate? Then blood diseases, like you already said,
Hemolytic.
Huh. So you will have to
Sir.
give differential diagnosis in this case.
Yes.
You will have to give differential diagnosis.
Congestive cardiac failure can also, sir.
Yes, congestive cardiac failure, which is a circulatory, you know. So you'll have to give differential diagnosis and then you would like to investigate the case. So what will be your differential diagnosis?
Any another portal hypertension cause of hepatosplenomegaly that we missed?
Yes,
Sir,
yes.
Congenital.
sir,
That is,
sir, Budd-Chiari syndrome can give rise to hepatosplenomegaly.
yes.
So many causes. So now you have put up the differential diagnosis for your splenomegaly because you know what is spleen? Spleen is an organ where both medicine and surgery meet together. Okay.
Yes, sir.
So you can get your medicine colleagues also involved because they can do lot of thinking. Surgeons do lot of hand action. Medicine colleagues do a lot of thinking and they can imagine, lot many conditions. So spleen is an organ. It's not me saying it is the common in the standard textbooks. The spleen is an organ, is a meeting point of medicine and surgery. It's given in your love and belief. Okay.
Yes, sir.
So now how will you investigate? What will be your first diagnosis and how will you investigate?
Sir,
Which
I
part
will
of
first,
India the patient is coming from?
sir, Gujarat, Porbandar, sir.
Okay, okay. So what will be your first diagnosis and why? Out of all this list, anything is possible, I can understand. बट उसमें से फर्स्ट क्या करोगे आप? ये मेरा पहला ये लगता है तो पहला ये देखेंगे, अगर ये नहीं है तो आगे चलेंगे.
Sir,
ऐसा बोलता
hemolytic
था.
anemia would be my first diagnosis, sir.
Why? Because I told you, liver is very large, spleen is very large. But yes,
Yes.
okay. Is it
So
endemic?
patient,
No. Then you have to justify. Is it endemic in that Porbandar area? Is Porbandar area known for hemolytic anemias or any particular?
Porbandar and Jamnagar surrounding that area is, sir,
Is
associated
is
with
it
hemolytic.
endemic for hemolytic anemias? चलो ठीक है. So you would like to give as hemolytic anemia. So what do you mean by what are the possibilities in hemolytic anemia? First, you have to confirm that this is hemolytic anemia.
Yes, sir.
So how will you confirm that this is hemolytic anemia?
Sir, I will go for a complete blood count with a peripheral smear and LDH reticulocyte count, sir.
Yes. Why you want peripheral smear?
Sir, in peripheral smear, if hemolytic anemia is present, then we can see fragmented RBCs, known as
In which
schistocytes, sir.
condition you will see fragmented RBCs?
Intravascular hemolysis, sir.
Yes, intravascular hemolysis is fine, but see, when you say hemolytic anemia, what are the pathological processes that you are anticipating? You are likely to get this. What are the various differential diagnoses of hemolytic anemia?
Sir, my first diagnosis would be sickle cell anemia,
Yes, yes,
G6PD anemia, and hereditary spherocytosis. And there will be thalassemia, sir.
yes. And what about ITP? Idiopathic thrombocytopenic purpura? That also gives rise to splenomegaly, no?
Yes, sir.
So, how will you confirm which test you will do for confirming hemolytic anemia? What is osmotic fragility?
Sir, normal RBCs are lysed at 0.47% of saline solution, sir. While due to membrane defect in the case of hereditary spherocytosis, RBCs are more susceptible for hemolysis by a less hypotonic
So,
solution, such as
osmotic fragility will tell you that there is hemolytic anemia or no hemolytic anemia, or whatever it is. Okay, then further you have to differentiate whether person has thalassemia, major, minor, spherocytosis, or idiopathic thrombocytopenia. So, how will you do that?
HB electrophoresis
Yeah,
is done.
and on Coombs test also. You will do Coombs test also, direct, indirect Coombs test. What is the importance of Coombs test?
Coombs test differentiate from autoimmune hemolytic anemia, sir.
Yes, yes. That is how you will do direct, indirect Coombs, osmotic fragility, the sickle cell test for sickle cell for sickling test for spherocytosis. Then by ruling out if nothing of this is there, but still you have confirmed hemolytic anemia, then you will go to idiopathic thrombocytopenic purpura.
Sir, may I speak? Which is the very first test you will do to rule out all these things before
Sir,
going to tickling or this
sir,
thing?
you are most welcome to come in at any time.
Yeah, no,
I, I,
which
I
basic
welcome
test
you.
you will do that will give you that there is confirmatory that this is the hemolysis is there, and then you proceed for Coombs or electrophoresis or whatever. That depends. That are differential. After
Sir,
CBC along with which test you will write?
serum LDH and
No,
reticulocyte count, sir.
no. Yes, reticulocyte count, because this is the first that production and destruction is higher. So production is higher. If
Yes,
reticulocyte
sir.
count is higher, then you stem that this is something is hemolysis is taking place, and then you proceed for all other test items. If reticulocyte is less than 2%, then it automatically ruled out. Then you have to go somewhere else.
Yes, sir.
It is possible that you don't get hemolysis as a cause in this particular patient because liver enlargement, to my mind, is three finger is pretty high for hemolytic as a cause. So you may land there may be involvement of the parasitic disorder, which can be a common thing like leishmaniasis, trypanosomiasis, something like that. It can be patient can have leishmaniasis, and it can be a parasitic disorder where there is a large splenomegaly. So you will need to do investigation for that. So and confirm if there is any parasitic disorder and treat it accordingly.
Yes, sir.
I'm sorry, it is leishmaniasis. In the initial phase, it's my slip of tongue and mistake. It's not trypanosomiasis, it is leishmaniasis. Kala azar is because leishmania donovan. Please correct it. Okay, so that is another possibility which could be very well be there because both the enlargements are pretty high. What about portal hypertension?
Mhm.
Is
Sir,
there
I
any
will get. Yes, sir.
possibility of portal hypertension?
Sir, Budd-Chiari syndrome give rise to both, sir, hepatomegaly as well as
Is there
splenomegaly.
any possibility of Budd-Chiari syndrome here?
Sir, there is a remote possibility, sir.
Yes, why? Because in Budd-Chiari syndrome or portal hypertension, you will see
Caudate lobe hypotension.
yes, and esophageal,
Varices, sir.
which is not there. The patient is not reporting any of the incidents of hematemesis, melena, or anything.
Yes, sir.
Plus, in clinical findings, in examination, there are no dilated veins on the abdominal wall.
Yes, sir.
Plus, There is no ascites. Is there ascites? No ascites. No,
No ascites.
no ascites. Portal hypertension, there will be some ascites, whatever may be the cause of portal hypertension. If it is cirrhosis of liver, it will be large ascites. But if there is a portal hypertension, there will be some ascites because of portal hypertension itself, because there is a back pressure and back flow. And you will get accordingly transudate type
Yes,
of portal ascites. There will be transudate because of high excessive pressure. Okay.
What is
yes.
leukemoid reaction? Leukemoid reaction.
Sir, leukemia reaction is routinely seen, sir, is seen during infection where WBC counts are more than, sir, 50,000. It can be misinterpreted as leukemia, sir.
So here, why it is not leukemia? You said that it's splenomegaly, hepatosplenomegaly. Can it not be a leukemia?
Sir, it can be leukemia. The patient is having multiple history of blood transfusion, sir, since starting at the age of 2 years, sir.
So now that there is a splenomegaly, we have ruled out things. So I am tempted to work various causes of splenomegaly.
Sir, various causes of splenomegaly include, sir, first infective cause,
Yes.
in which protozoal causes are malaria and leishmaniasis, sir. In the bacterial cause, there will be splenic abscess, tuberculosis, uh, and salmonella, sir. In a spirochete, syphilis can give rise to splenomegaly and leptospira, sir. Viral causes are HIV and infectious mononucleosis, sir.
Then
Uh,
next one is blood disorders, which we have
yes,
already
sir.
discussed now. Okay.
Yes, sir.
Then third one is
Circulatory causes, sir. Congestive cardiac failure, sir.
okay.
And portal hypertension, sir.
Fourth one is
Uh,
metabolic.
vascular close, sir.
Vascular causes come under
Met-
circulatory causes. They are already included.
yes,
Then
sir.
next
Splenic
one,
vein thrombosis, sir. Yes, sir.
metabolic. No? So after
Meta, um,
like Gaucher's and
amyloidosis, sir.
yes. Then comes what? Amyloid.
Hematological causes.
Then
Yes, sir.
connective tissue.
Hematological causes also include immune thrombocytopenic purpura and malignancies, sir. Myeloproliferative syndrome and leukemia, sir.
Then comes the connective tissue disorders, collagen disorders, not connective tissue, collagen disorders.
Yes, sir.
You will have
Felty syndrome and Still's disease, sir.
Then is your malignancies like
Yes, sir.
leukemias, and then
Secondary metastasis,
cystic disease. You can have certain cysts. What is the commonest cyst
polycyst,
that you can see in the spleen?
simple cyst, sir.
Yes, simple cyst. What else? Any disease can, in India, can any disease present as a cyst of the spleen?
Hydatid cyst, sir.
Yes,
Hydatid disease.
good show, good show. Yes. Vaishnav, sir? Dr. Vaishnav?
Dr. Shivang, what
Yes, sir.
condition can cause autosplenectomy?
Sir, in sickle cell disease, autosplenectomy.
Okay,
Can you?
good.
Is patient is coming from Porbandar, is farmer. What do you think? Any other cystic lesion? Whether can liver is somewhere hiders and spleen is also enlarged, can enlarge infective
Leptospirosis,
condition.
sir.
No, leptospirosis is not common in that part of Gujarat, and that is not a long-standing history. Another thing, cystic lesion.
Hydatid disease, sir.
Yes, sometimes hydatid may have upper lobe of the liver hydatid is there that not palpable, and spleen may have multiple hydatids also. May.
Yes.
Okay, so how will you go about treating this particular patient? Suppose we take as your diagnosis as hemolytic disease. Okay.
Sir, after
Sir,
confirmation of,
just one thing. Shivang, do you know,
yes, sir.
do you have the reports?
Yes, sir. I have a USG of the patient and report of HPLC, sir.
Okay, so what does it say?
Sir,
Sir, this is the
HPLC is
actual
just
patient, so we can always continue with the therapeutic definitive treatment, sir.
Yeah. First, if the
Shivang.
reports are available, he can give the actual report. So
Yes, sir.
the scenario will
yes, sir.
be very much close to reality.
Right, sir.
You
Bol
can,
beta.
if you can
Sir,
give actual reports,
sir,
yes.
USG is suggestive of hepatosplenomegaly with liver size is of 15.7 centimeter and a spleen size of 16.3 centimeter. And HPLC is suggestive of beta thalassemia major with HbA2 7.7% and HbF is 92.8%, sir.
So
Supposing how would the hydrated cyst of liver and spleen, the radiological report would be? Ultrasound, what will it show? What is the difference in the ultrasound of
Sir, in ultrasound,
hemolytic disease and in, say, liver, this hydrated disease?
sir, in hydrated disease, there will be cystic lesions seen in both if there is present in liver and spleen. With daughter cyst can sometimes be seen and also characteristic of water lily sign.
Right. And even wall calcification if it is there.
Yes, sir.
Right. Okay.
And in if hemolytic disease is there, then both spleen and liver will be enlarged without any change in architecture, sir.
what are the various layers of the wall of the hydrated cyst?
Sir, hydrated cyst has three layers, sir.
Hmm.
Pericyst, ectocyst, and endocyst, sir.
Okay. And what is brood capsule?
Brood capsule is a capsule formed by a daughter cyst, which
Yes.
is
So now here you have come with the ready reports and the diagnosis is staring at you. So what do you think this patient should be? Uh, what should we do to this particular patient?
sir.
Treatment and further advice.
Sir, HPLC though is suggestive of a beta thalassemia measure, but patient at the age of 38-year patient has received only blood transfusion till 5 times only. So I would like to keep patient conservative, sir.
Yes, okay, because it's a beta thalassemia major. So is there any role for splenectomy in beta thalassemia major or there is no role for splenectomy?
Transfusion dependent beta thalassemia measure if present, sir, then we splenectomy helps to reduce transfusion frequency, sir.
Mm, generally, you do splenectomy so regularly for transfusion dependent beta thalassemia. Blood bank people would have been very happy, and pediatricians would have been very happy. They have to have those
Sir,
thalassemia clinics. They have got big thalassemia clinic where the people come for regular transfusions, isn't it?
sir, when transfusion require is more than 200 ml per kg per year, then it is indication for
What
splenectomy.
I'm asking you is, can really splenectomy substitute for transfusions? That is what is the question in order.
No, sir,
Which is
it
the
is not
hemolytic,
substitute for
which is the
transfusion, but
hemolytic
it
disorder
reduces frequency.
which is the hemolytic disorder where splenectomy gives the best results. See, you have got spherocytosis. See, when you are talking of hemolytic disorders, there are 4 or 5 disorders: spherocytosis, thal major, thal minor, ITP, and idiopathic
Yes, sir.
hemolytic.
Yes, sir.
So, which is the disorder in 5 of these, which you get the best results of?
Sir, ITP.
I mean, spherocytosis. Spherocytosis, you get best result. ITP, you are doing splenectomy. Yes, to reduce the that whatever you said just now is more valid for ITP, you to reduce the requirement. That can only reduce the requirement.
Yes.
The best results you get in spherocytosis. Your splenectomy and destruction goes, because the disease in spherocytosis is not in the organ, it is in the red blood cells. Spleen is the only organ which is destroying it. So diseased blood cells you cannot change. You cannot change the diseased blood cells, but you can stop destruction.
Yes, sir.
You said that
Driver?
this thalassemia major,
Yes, Prashant.
but is there any role of platelet count?
Sorry, sir.
You said that patient is thalassemia major. Okay.
Yes, sir.
So considering the splenectomy, platelet count is considered or not? You
Sir,
said only the repeated blood transfusion is the only indication.
sir, secondary hypersplenism, if there is a present, then we can go for splenectomy, sir.
What are the levels that you will decide? Up to below this platelet count, you can go for splenectomy in thal major.
That I don't know, sir.
Usual borderline considered is WHO consideration is 70,000. 70,000 platelet count is ideally considered an indication for splenectomy.
Another question which the examiners are tempted to ask, which is very specific to what is Felty's syndrome. You know what is Felty's syndrome?
Yes, sir. It is a rheumatoid arthritis with neutropenia and splenomegaly, sir.
Yes, and what is hypersplenism?
Sir, hyperplanism is a condition in which uh, two lineage of circulatory cells are reduced, sir. There should be two lineage of reduction in number of two lineage of cell associated with it may be or may not be associated with a splenomegaly, and it is reversible after splenectomy, sir.
Yes, and third thing is in our Kala Azar is very common. So you will get spleens with Kala Azar, patient with spleens with Kala Azar. So if you are a patient who is having large spleen, Kala Azar spleens are generally large because clinically you classify splenomegaly in mild, moderate, severe. So Kala Azar spleens generally go into
Yes, sir.
severe. What is the treatment? What would you do to that severe splenomegaly, large spleen?
Massive splenomegaly should be, sir, opt for splenectomy, sir.
Yes.
It
Why?
has high chances of rupture, sir.
Yes, absolutely, absolutely. High chances of rupture. So you're worried about rupture. How does the splenic rupture present to you? Splenic rupture generally present to you in three types. No? What are these three types?
Sir, generalized abdominal pain will be present, sir, with Kehr sign may be positive, sir.
No, care sign may be positive only one particular presentation. One presentation is very severe presentation. That splenic rupture is very severe. Whole spleen is shattered and patient just collapses.
Yes, sir.
That much severe is the bleed. He may just reach the hospital. Second presentation is there is a splenic rupture, but then after certain amount of time, the patient deterioration stops and he shows some signs of recovery. That is the sign you will get that care sign.
Yes, sir.
And what is the second sign? That one is care sign, and the second one, I forget name, but I think it is Boas sign. Boas sign, BOS. What is Boas? I don't. But that sign where you get shifting dullness in both the flanks. You get dullness in both the flanks. And what is the character of dullness? It is shifting only in right flank. It is not shifting in left flank. Why is it not shifting dullness in left flank, but shifting dullness in right? Both flanks you get dullness. The dullness in right flank is shifting dullness. Left flank is dullness. It doesn't shift because there is a blood clotting, hematoma, and coagulation around the spleen on the left side. So you may not get the dullness on the left side does not shift.
Yes, sir.
So that is what it is. What is delayed rupture? Third presentation is delayed rupture. What is delayed rupture of spleen and when does it occur?
I don't know, sir.
A delayed rupture of spleen in case of such things or trauma or the spleens which are amenable for rupture can occur up to 15 days. Mainly after trauma, there is a hematoma inside the spleen. The delayed rupture can occur up to 15 days or sometimes even more, but generally up to 15 days. And you should be aware about this. And in case of any splenic injuries, hematomas, you should observe the patient for about 15 days.
Yes, sir.
So,
सतोषकर सर
बोलिए सर.
सर सर मेरा फ्लाइट निकल रहा है आई हैव टू बोर्ड आई हैव टू गो थैंक
No
यू
problem,
सर
sir.
प्लीज
It was
कंटिन्यू भाई आप डॉक्टर विनीत भाई
Sir, I'm here, sir.
या प्लीज कंटिन्यू सर हाँ मुझे अभी निकलना पड़ेगा
If we
Okay,
are
sir.
late, we can stop here. No problem. But we have
No,
completed.
sir,
Almost,
continue.
we have touched
नहीं
all the
सर
points.
कंटिन्यू नहीं सर कंटिन्यू आई एम सॉरी टू इंटरप्ट कंटिन्यू सर
नहीं, but
एक्चुअली
I
मुझे
think we
11
have
बजे का
touched
मालूम था
most of
लेकिन
the
मुझे
points
निकलना
also.
पड़ेगा
I think we have touched
राइट
most
सर
of the points.
प्लीज कंटिन्यू सर
Okay, sir. I'll just
यस
coordinate.
प्लीज कंटिन्यू
Sure.
ओके थैंक यू
Acha.
Dr. Vineet, please.
Yes, sir. Yes, sir. Uh, Shivang,
Yes,
what
sir.
is the difference between an elective splenectomy and emergency splenectomy?
Sir, in elective splenectomy, we have to ligate at the hilum. We have to ligate splenic artery first, and then vein separately. And while in emergency splenectomy, we directly apply clamp at the hilum and ligate and pass.
No, it is not so simple. Vineet, it is
And
much more than this. Emergency splenectomy, what is the technique known? And it is Reeves technique. REVS, Reeves technique. What is Reeves technique? And from where do you approach the hilum? In case of ideally, I am talking about ideally. In emergency splenectomy, what is Reeves technique? See, emergency
hilum.
splenectomy, you have to be very fast. You have to stop the bleed as early as possible. You have to go down to the splenic hilum, splenic veins, and artery as early as possible. So what you do is you put your hand into the left hypochondrium lateral to the spleen, and with the hand you just break the or tear the or tear whatever ligaments are there lateral to the spleen or whatever adhesions are there. Just you put the hand, and with one just single this movement of the hand, you separate the spleen from the abdominal wall. You just put hand like this, and with just one movement, separate the spleen from the hand, separate the spleen from the abdominal wall, so that the spleen comes into your operative field or whatever incision you have said, and then you quickly go as fast as possible toward the splenic artery and splenic vein, and you put the clamp on the main pedicle, that is splenic artery and splenic vein. So that is how you do
In emergency.
emergency reuse technique. Now, what is the standard, elective splenectomy? Elective splenectomy, first you go anteriorly, you ligate all the short gastric vessels.
Yes,
Okay?
sir.
You ligate all the short gastric vessels. Then you slowly and steadily, you open up the reflection, that is the reflection onto the spleen from lateral parachoric gutter or to the peritoneal fold which goes from over the colon, anterior surface of colon towards the spleen, you know.
Yes,
So you open it up and you go on to the posterior side of the spleen onto the pedicle and expose the pedicle. Then you see both splenic artery and splenic vein. And then you hook around the main splenic vein and ligate the main splenic artery, and you ligate the main splenic artery. After ligation of the main splenic artery, the blood flow to the spleen will be stopped, but blood drainage from the spleen continues. So the
yes, sir.
as much as blood from the spleen gets into the circulation, the spleen shrinks, so you don't waste that much of blood. So the of course, the spleen is a very vascular organ and it will maintain some amount of blood, but the amount of blood that will go out with the spleen will be much less. So you allow that to happen, you allow the spleen to shrink, okay?
Yes, sir.
Yeah. You allow the spleen to shrink, you open up the lienorenal ligament posteriorly and go on to the pedicle. You first break the adhesions or the reflections from the abdominal wall onto the spleen, you turn the spleen, go to the lienorenal ligament, open up the lienorenal ligament, and through lienorenal ligament opening, you go to the splenic pedicle. First ligate the splenic artery, allow the spleen to shrink, and then ligate the splenic vein. And then you pick up the spleen and get it out. And this is required because most of the times when you are doing elective splenectomy, the size of the spleen is very large. So if you try to do that technique where you put your hand, break everything, and just put the clamps, it may be difficult to go on the pedicle because the size of the spleen itself will come in your way.
Yes,
Okay.
yes, sir.
So in this elective splenectomy, when you separate the spleen, you may not get the spleen out of the operative incision, but you can turn the spleen within the abdomen itself towards the right side, towards the liver side, so that you can go on to the lienorenal ligament and
Ligating
open
curves.
up the lienorenal ligament, and you can ligate the thing. And once you are ligated the blood supply, you can turn the way you want the spleen inside the abdomen, and you can just negotiate it out of the abdomen. So first ligate short gastric and then go on to the splenic pedicle. Once spleen is completely avascularized, it's not difficult to pull it out of abdomen with courage. Before you ligate splenic artery, you are worried because if you are not able to, you know, control it, if it slips, then it is very difficult because it, just gets retracted into that tissue. You can catch, of course, but it's unnecessarily there is a blood loss. So that is the difference between elective splenectomy and emergency splenectomy. Emergency splenectomy, many times the size is small and you have speed is the essence. So you have to just deliver it as early as possible. Modi sir, Dr. Modi.
Sir, I think Dr. Modi has left due to some prior engagement.
Okay.
So I think
So I
we'll
think
take.
now we can conclude this session.
Okay, sir. We
Or
can.
anybody wants to discuss anything, or anybody wants to ask any questions?
I just wanted to tell uh, Shivang that in
Yes, sir.
inspection he said that the
Yes, sir.
abdomen was scaphoid. Actually,
Yes,
if
sir.
there is a large spleen, which is almost 7 centimeter below the this mid clavicular line, so you
Yes,
have
sir.
to say that there is fullness of the left hypochondrium. You cannot say that it's a scaphoid abdomen.
Yes, sir.
Uh,
Yes,
so
yes.
that is very important. You will get trapped here only in the exam.
Yeah.
Yes.
Because
Another
there
thing
will
is,
be a lump. There will be a lump over there.
and another thing is that you also have to talk about is there any role of endoscopy, upper GI in any
Yes, sir.
splenomegaly?
Yes, sir.
So would
Uh,
you like to go
to,
for a endoscopy?
sir, endoscope. We if we want to exclude esophageal varices, sir, then
Because there is
in case of portal
hepatosplenomegaly.
hypertension,
Yes, you may not go directly go for a this Like if you are suspecting if in sonography there is hepatosplenomegaly, I think we should go for an endoscopy also. That will also give us an idea whether it is portal hypertension or something else.
Yes.
And last one is, laparoscopic splenectomy. So you belong to which group? The Durbinwalas or non-Durbinwalas?
Sir,
So
small
last one
spleen.
is laparoscopic splenectomy and robotic splenectomy.
Sir, small spleen and mild to moderate splenomegaly can be removed by laparoscopic, while massive splenomegaly needs open approach.
Now indications, just some of the indications for splenectomy.
Sir, main indication is hypersplenism, sir. And in case of
ट्रॉमेटिक वगैरह ऐसा कुछ है कि नहीं?
yes, sir. In case of splenic trauma, grade 4 and 5 injuries, and in few cases, grade 3 injuries, sir. In case of
Parasitic disease, infective disease.
yes, sir.
There
In case
are indications.
in case of infective disease, if there is a massive splenomegaly, then if we fear the chances of rupture, then we can go for splenectomy also to alleviate the patient's symptoms, sir. Also, in case of a CML, sir, if massive splenomegaly is present, then we can go for splenectomy, but
In
chemotherapy should be.
which kind of lymphoma, lymphomas do you need splenectomy? Any lymphomas?
What is staging laparotomy?
Yes.
Shivang, hello.
Yes, sir.
What is sir is asking about what is staging laparotomy?
Yes.
Sir, it was done for Hodgkin lymphoma.
अरे फेमस लिम्फोमा ऐसा क्या बोलता है? रीड स्टर्नबर्ग सेल किसमें होता है?
Hodgkin lymphoma, sir.
आप फिर इतना
It
बड़ा
was
आंसर है आपके सामने.
for yes, sir. For stage.
Okay, sir. Dr. Apurva, sir, are you there?
So sir
Sir,
is not.
sir has left. Sir has left for his.
I think it's almost 1.5 hours. So
Yes, sir. We can conclude, sir. And
you
thank you
can
so much, sir. For
and give some breathing time and self-study time for the students. So now they can go back, look up the books, and try to consolidate whatever we are discussed here today. Yeah.
yes, sir. Yes, sir. Sir, we had a very interactive session with you, sir. Thank you so much for joining, sir. Thank you very much. And Mehta, sir, also thank you very much for and all the examiners and thank you to all of them. Thank you,
I
sir.
hope
Now
all
we are closing.
the participants have enjoyed the session.
Thank you,
Yes,
sir.
Shivang.
Yes, sir.
Shivang represents the student community, so I hope all the participants have enjoyed. Shivang is
Yes, sir.
saying what kind of questions sir is asking. Nobody enjoys exam,
Yes, sir.
isn't it?
No, sir. It was,
I
sir,
can
very
understand. I
informative, sir.
can understand. Don't worry.
Okay, sir. So we can close
Bye.
now.
Yeah. We can.
Thank you so much.
Thank you.
Okay, thank you. Thank you,
Yeah.
Shivang.
Thank you.
Sir. Thank you, sir.